Let's ask now about when patients should be tested. And Dr. Sandler, let's say that we have a stage 4 patient with an adenocarcinoma. Should the testing be done early on at the time of diagnosis, or only when you need to make a treatment decision?
Well, I think that early on is becoming more important because that's when the treatment decisions actually are going to be made now with the EGFR mutation and with the ALK translocation, since those are patients who potentially can receive treatment that would supersede that of chemotherapy. I'm sure we'll be talking about that throughout today. And so I think the way I sort of practice medicine has been related to what I learned in medical school, to not order a test unless you're going to do something with the information. And I think these tests, these two tests are clearly designed now to determine what our treatment is going to be. And so the earlier you can do it, the better, because there is a time that's necessary to get the results. And so depending upon the likelihood that I think they're going to be positive will also help to dictate what I may do. So I may actually not wait for the results, depending upon where the testing occurs. And I suspect we'll talk about that too. That comes into play, again, based on sort of the phenotype, if you will, of the patient.
Well, that brings up an additional question, Alan. Let's say that you actually have a patient who has a stage 2 adenocarcinoma of the lung and undergoes surgical resection, and that patient is fairly young and a never smoker. Would you do the testing up front, even though you might not use the information then, or only if they develop recurrence?
Yeah, it's a good question. Again, hearkening back to what I mentioned about using the test for information, since there isn't clear data at this point outside of potential studies to utilize either the EGFR TKIs or crizotinib in the adjuvant setting, we don't necessarily test them immediately. I think they have some prognostic value potentially, which certainly can be informative, and it's reasonable to test, but I wouldn't be acting upon it clinically.
One of the other issues that comes up is sometimes insurance won't cover it in the early stage because there's no indication.
Well, I think they will now because it's going to be in the guidelines.
We've taken a different tact, particularly in node-positive patients who still undergone definitive resection. We have plans for adjuvant and certainly don't have an immediate plan for targeted therapy. Unfortunately, they're still at high risk for recurrence, and we prefer to have that information banked. As you're well aware, it can take 2, 3, even 4 weeks sometimes to get these tests back when you do it at the time of recurrence, and that's valuable time in their lives. And I'd rather have that information a priori. Now, you could argue, well, maybe there are new mutations or other issues that come up at that point, but increasingly, we are now at least assaying for EGFR mutation and EML4 ALK translocation in that population.
Yeah, I mean, I certainly wouldn't disagree with that. I think we've done it. I've seen sometimes where we have ended up doing that, where sometimes the surgeons might be ordering the tests as well. There's a lot of different people that have the opportunity to order these tests, and I'm sure we'll be chatting about that momentarily.
This is probably also a good time to bring up the point that the National Cancer Institute will be initiating some adjuvant trials in surgical patients specifically for the populations with EGFR mutation, and a separate trial for those with ALK fusion. In order to screen for that, a large program which will be led by Alliance called Alchemist is going to be launched, where actually 8,000 early stage patients will undergo molecular testing so that they would be candidates for these trials, but the information will then be available for later use as well.